Good morning, everyone. On behalf of the Center for Behavioral Health and Justice, the Michigan Health Endowment Fund, the Michigan Opioid Partnership, I welcome you to the Opioid Treatment Ecosystem Community of Practice Virtual Summit. I am Liz Tillander, the Deputy Director for the Center for Behavioral Health and Justice. The CBHJ is a community-based research center at the School of Social Work at Wayne State University. And we provide local communities, organizations, behavioral health, and law enforcement agencies with technical assistance, evaluation, and support to optimize the diversion of individuals from jails and prisons. We are also very thrilled that you chose to be here today. You are among 500 attendees, including first responders, jail administrators, frontline staff, medical professionals, behavioral health providers, those directly impacted by the overdose crisis, and the state of Michigan and funding partners. So welcome and thank you for being here. Over the next 2 hours, you will hear about the tremendous work that's being done across the state of Michigan in response to the overdose crisis. You'll hear from our own director, Dr. Brad Ray. In addition, you'll hear from 6 counties that are expanding their treatment ecosystems, including Jackson, Kent, Monroe, Muskegon, Washtenaw, and Wayne. We'll then wrap up with a discussion on how to expand treatment ecosystems even further and hopefully inspire other communities to engage in similar work. This summit was originally envisioned to be an in-person event, but like many events, the COVID-19 pandemic forced a move to this virtual format. My kudos to our CBHJ team, especially Ronnie Kaysen, Nicole Hamame, Liz Leidens, and Aaliyah Washington for their efforts in adapting and moving to this online platform. Just a note about this online platform. In an effort to facilitate a high-quality event free of distractions, the microphone feature for attendees has been disabled to eliminate all background noises. While you will not be able to verbally engage with presenters and our panelists as you would in person, we encourage your use of the Q&A feature at the bottom of your screen to pose any questions you have throughout today's event. We promise that we have reserved enough time for our panelists to answer your questions before the end of the summit. Before we begin, we must acknowledge the generous support of the Michigan Health Endowment Fund, the foundation that has made it possible for this event as part of the Opioid Treatment Ecosystem Community of Practice. This morning, I have the great pleasure to welcome Terry Gardner of the Michigan Health Endowment Fund to offer opening remarks. After over 30 years in accounting and investment worlds, covering all aspects of management, operations, compliance, and investment, Terry Gardner made a career change and joined the nonprofit world to help lead the formation and operation of the Michigan Health Endowment Fund. The Health Fund is a philanthropic foundation that works to improve the health and wellness of Michigan residents while reducing healthcare costs. As the Chief Operating Officer, Terry provides executive leadership for all program areas, including behavioral health, helping communities overcome tremendous barriers to treatment access. In the spirit of integrating and breaking down silos at the Health Fund, under Terry's leadership, he has invested in creative work with first responders and jails in Kent and Monroe counties, and you'll hear about them today. Generous funding from the Health Fund supports statewide community of practice that is working to expand local treatment ecosystems and makes it possible for the CBHJ to lead communities and learning communities and opportunities like the one you're participating in today. Welcome, Terry.
Thank you, Liz. First, I want to thank everybody for participating in this and being willing to do this virtually rather than in person. 500 people is a lot of people. It shows the importance of the work that you're doing, and I just want to thank you all for making the time to do this. At the Health Fund, we view our role as being a vehicle both in people and in dollars to facilitate passionate people like Linda Zeller, who is our senior program officer heading this work up, Cheryl at Wayne State, and all of you in your local communities fix issues that have been impacting your residents. The opioid work that we are funding is easily our highest profile project right now, both in terms of the people that are allocated to it, the amount of time we're spending on it, and the amount of money that is allocated. And I must say, when we brought this to the board, it was very much a trust us sort of a project. It was 3 or 4 times bigger than anything we had attempted before. The work that Cheryl and Linda were proposing was cutting edge, and the amount of and the difficulties in the local communities, both individually for all of you who are participating, the organizations that are participating, and politically, were huge barriers to overcome. And I want to congratulate all of you for all the success that you've had in your first year. I specifically want to thank the communities and the counties that are participating. Kent and Monroe, we're doing some extra things there, or you're all doing extra things there in the jails and with first responders, and it's really cool to see how that work is progressing. I will say that Linda is giving a presentation on your work next week at our board meeting, and I think that they're going to be equally excited to see how much progress you've made, and we hope that year 2 of this project is even more successful than year 1. Thank you very much for all the work that you're doing, and we're just thrilled to be able to have people who are passionate about fixing issues in their communities, and we're just glad to be able to help them. Thank you.
Thank you so much, Terry, and good morning, everyone. My name is Nicole Hamame, and I'm a project coordinator at the Center for Behavioral Health and Justice. Our first presenter today is Dr. Brad Ray, who joined Wayne State University's School of Social Work as Associate Professor and Director of the Center for Behavioral Health and Justice in 2019. He received his PhD in sociology from North Carolina State University in 2012 and served as research director at the Indiana University Public Policy Institute for 7 years. He is a community engaged researcher who focuses on mental health and substance use, particularly where these populations intersect with the criminal legal system. Much of his recent research has focused on evaluating policies and interventions aimed at the recent overdose epidemic and translating evidence-based strategies into practice. Dr. Ray joins us today to provide an overview of the overdose crisis and to explain how the Center for Behavioral Health and Justice is responding.
Good morning, everyone. I really want to thank all of you for joining us. My name is Dr. Brad Ray. I am the director of the Center for Behavioral Health and Justice and an associate professor in the School of Social Work at Wayne State University. I've been doing research around overdose prevention for over 15 years now, and I was initially interested in this topic after someone close to me had a non-fatal overdose from heroin use. And at that time in my life, I felt really compelled to try and understand the stigma around this disease. And my first research experiences were with a harm reduction program in Chicago, the Chicago Recovery Alliance. It's one of the oldest syringe service programs in the United States. And while I was there, I did interviews with injection drug users. I learned a lot about heroin use and drug use, but I learned more importantly about the importance of harm reduction services in these folks' lives. And as part of that project, what we were doing, we were using fatal overdose data to try and understand where these harm reduction services could be provided. So Chicago had a mobile unit, and it could be stationed anywhere in the community to provide community outreach to help reduce overdose deaths. So it was as a graduate student back then on this project that I was collecting death certificates. And I learned a lot about death certificates, and I learned a lot about toxicology results, and that these are very different pieces of information. Death certificates can tell you that someone died of a drug overdose, but the toxicology results can tell you the specific substances in that overdose. And this knowledge has proved very valuable to me in understanding this most recent overdose epidemic. Would you mind going to the next slide? Thank you. So in 2012, I started a job at Indiana University, and I immediately started a collaboration with the county coroner in Indianapolis to collect toxicology data. So we actually started collecting data 2010 forward, so we went back and got information. And at that time in 2012, as we were collecting the data in real time, I was meeting with a group of community stakeholders pretty regularly, including the chief of police, and we were looking at where there were increases in heroin overdose deaths and crimes that might be related to it. And at this point in 2012, we had never seen this high a number of deaths that contained heroin in the US or in Indianapolis. And so during that time, we were doing work on training law enforcement to administer naloxone. And we had that kick off in 2014. And it was in that same summer that the student who was inputting the overdose data called me to ask me what fentanyl was. Said it was showing up in all of the tests. And I Googled it. I did not know what it was beyond that. I talked to the group that we were working closely with there in Indianapolis, and I called the coroner's office and I asked them if they had changed testing procedures. But really what happened was that summer fentanyl hit Marion County in Indianapolis. At that time, it was in almost half of the overdose deaths, and now it's in well over 2/3. But it was that summer that my perspective on this epidemic changed. And I was very clear in telling people that this was just no longer about prescription medications. Certainly, that's not a problem that should be minimized. Across America, doctors overprescribed pain analgesics and millions of pills were diverted illegally. And it's a problem that's played a huge role in getting us to where we are today. Because when that supply of diverted opioids, those pills decreased, people moved to illicit versions of opioids. And initially, this was in heroin. And in 2012, when we thought overdose deaths couldn't go any higher, when for 5 years, accidental overdose deaths were outpacing motor vehicle accidents as the leading cause of accidental death in the United States, fentanyl came along, a drug 50 times more powerful than morphine, and we saw drug overdose deaths increase exponentially for 3 years straight. These trends have generally been referred to as waves of the overdose epidemic. And as you can see, if you could go to the next slide, this not only has occurred in the United States, this pattern has also occurred in Michigan. Many recent researchers have recently pointed out that we've entered a fourth wave that's emerged as we see large increases in methamphetamine and cocaine that are being co-used alongside of combined heroin and fentanyl substances. These seem to consistently be detected amongst each other. But in reality, America has been in an evolving overdose epidemic for over 30 years. But right now, with COVID-19, we are in a syndemic. These are two epidemics that are occurring at the same time and compounding each other to cause more harm. And make no mistake, while there's going to be regional variation and debate amongst EMS responses and naloxone use, overdose deaths are increasing. Unfortunately, we weren't able to get the real-time data here in Michigan or Wayne County, but in Indianapolis, we've already detected a 35% increase in overdose deaths following stay-at-home orders. Isolation and loneliness have an overwhelming effect on addiction that increases the risk of overdose. So while COVID-19 has all of us shifting our priorities, we need to recognize that the overdose epidemic is not going away, and it's probably going to get worse. We need to double our efforts to use evidence-based solutions, but we also need to develop new skills and tools to address this. And unfortunately, correctional facilities are at the epicenter of this pandemic. They have been disproportionately impacted by COVID-19. And as everyone here knows, the American criminal legal system is set up to come into contact with those who have developed a chemical addiction. And this is especially true for those addicted to illicit opioids. People in jails are twice as likely to have an opioid use disorder, and they're at very high risk for overdose at release. People rapidly develop a dependence to opioids. And when they leave an incarcerated time period, they believe they can take the same amount as before. They believe they have the same tolerance, but when in fact it's actually changed. Studies suggest that people leaving jail are 120 times more likely to die of an overdose. In Indianapolis, where there's about 400 deaths per year, we find that about a third of those, or over 125 people, were in the county jail in the year prior to their death, many days prior to release. And as someone who has linked EMS data and prescription drug data and treatment data to overdose data, I can tell you that jail consistently emerges as a salient touch point where we have an opportunity to intervene. And for opioid use disorder, there is no treatment modality with better evidence than medications for opioid use disorder, also known as MAT, medication-assisted treatment. We prefer MOUD. This includes methadone, buprenorphine, and naltrexone. But unfortunately, far too many of those who need these medications have barriers to accessing them. And no place is this more apparent than in our county jails. Less than 1% of jails in the United States provide these medications, and even fewer provide all three. Yet the research consistently tells us that if we implemented these medications, that we could save thousands of lives per year in the United States. To address this, the Center for Behavioral Health and Justice, with funding from the Michigan Opioid Partnership and MDHHS, has developed the Opioid Treatment Ecosystem, or OTE as we call it. This is a technical assistance framework that's aimed at strengthening community-based treatment at the intersection of criminal legal systems. A key component of a community's opioid treatment ecosystems are the availability of medications for opioid use disorder in the county jail. If you wouldn't mind going to the next slide, we have developed a model that includes the use of a validated screening tool, access to all three medications with induction for new patients, adjunctive psychosocial services, and a continuity of care plan post-release that includes naloxone distribution. But the opioid treatment ecosystem also focuses on pathways to treatment outside of the jail. Proactive response to overdose and appropriate connections to treatment, which we call PROACT, are community-driven post-overdose response programs that we are helping to facilitate and evaluate to identify best practices. Over the past 9 months, I've had the privilege to work with some incredible staff and heard some amazing success stories come out of these OT counties. And today, I'm just truly excited for you all to hear from a group of remarkable pioneers. These stakeholders have helped to transform their communities and expand their opioid treatment ecosystems. By reducing barriers and creating new pathways to treatment, these efforts are poised to improve the lives of Michiganders and dramatically reduce overdose deaths in the state. Thank you all very much for joining us, and I look forward to hearing from our presenters today.
Thank you so much, Brad. Next up is Major Troy Goodenough, who has 29 years of service with the Monroe County Sheriff's Office. Prior to his current role as Major of Jail Operations, Major Goodenough worked as Lieutenant District Commander, Road Patrol Sergeant and Officer, Corrections Officer, and has held many other leadership roles at the Sheriff's Office. He has a Master of Public Administration from the University of Michigan Dearborn and strongly believes in giving back to his community by serving on several community boards and committees. Major Goodenough's extensive experience in the Sheriff's Office and commitment to his community makes him a strong advocate for implementing change to expand and improve cross-systems coordination in Monroe County. Today, Major Goodenough will be sharing plans for expanding the treatment ecosystem in Monroe, one of the OTE communities funded by the Michigan Health Endowment Fund. Welcome, Major.
Good morning, everyone, and thank you for the opportunity to present some information on behalf of the Monroe County Sheriff's Office and that fine introduction. So I want to start out just providing an overview of our community. We have a population a little over 150,000. We're bordered by Wayne County, Washtenaw County, Lenawee County, and Toledo, Ohio to our south. A number of initiatives here in our department. We have Stepping Up, Mental Health Jail Diversion, and the Michigan Reentry MyRep 2 program. Our current initiatives involve the medication, OUD in jails, the screenage and the linkage, continuity of care, pre-release and post-release, as well as post-overdose response. And that's a program that we established with all of our police agencies in the community, whereas when they respond to an overdose and Narcan is administered, they then fill out a referral form, and we, within a reasonable amount of time, we'd like to say within 24 hours, we send a peer support or clinician out to meet with that individual where we feel they're most vulnerable, which is within that short period of time of overdose, in an attempt to get them into a program to get them some help. As far as what we're doing in the corrections setting, we utilize a RODS report and a K6 screening tool. All individuals within our organization are screened, and we currently have a 20% positive response rate in our data collection period. One of the things that the Sheriff's Office values is the collaboration with our community partners. We not only collaborate with other law enforcement agencies, EMS, fire, but we also involve parole, probation, and a number of people within our community that provide substance abuse disorder and behavioral health to not only our inmates, but the consumers within the community once they're released from jail. One of our partners is Passion of Minds. It's Passion of Minds Healing Center. They are an medication-assisted treatment therapy provider, and Monroe Community Mental Health. I'm happy to say that yesterday we executed the MOU to foster our relationship with Passion of Minds. I can tell you that in the last week, they've been in our facility twice to administer medication, and particularly methadone, to consumers of theirs who were arrested for a criminal activity. And to maintain that continuity of treatment, they agreed to come in and administer that methadone. Even before we had the MOU actually signed, we saw the value in that, maintaining that continuity of medication, so the inmates didn't start to withdraw and maintain their care. And as you well know, giving them the medication that they need to sustain their disorder helps them be easier to manage in our institution. Again, how do we identify these individuals when they enter our facility? We use the screening tools that I previously mentioned, but we also dive into it a little deeper at the time of booking. And if they do indicate that they're on a medication-assisted treatment, whether it be Vivitrol, Suboxone, methadone, then we convey that information to Passion of Minds along with our medical department, and we will immediately evaluate these individuals to determine what level of care they need to help them get through their stay. Our therapeutic supports co-occurring mental health. As was mentioned, we have a behavioral health unit here at the Sheriff's Office, which was grant funded through our partners at Wayne State. And as we know, substance abuse disorder and behavioral health are co-occurring disorders, and they go hand in hand. And one of the things that we think what sets us apart from others is we have both teams within our institution, so they can collaborate together to ensure the continuity of care, but the quality of care is very high. And we can provide dual recovery services while they're in jail and as we prepare for their release. We also have our partners at Community Corrections that assist us as well, getting the inmates into programs while incarcerated and preparing for treatment and discharge planning when they return to the community to ensure the continuity of care. As mentioned earlier, we do use Vivitrol, naltrexone, Suboxone, methadone, and currently our programs are all grant funded. When I say our programs, I mean our substance abuse disorder. Our behavioral health program was grant funded. Unfortunately, when them grant funds ran out, we had to seek alternative funding, and our partners at Community Mental Health picked up a portion, and our legislative body, which is our Board of Commissioners. It was reassuring to know that we went in front of them and asked for the additional money to fund that position. It was a 9-0 vote without even a question. And I say this was, we were successful in securing these funds through our legislative body because monthly, quarterly, we provide them with statistical data which shows and displays our outcomes and the value of this program to the citizens of Monroe County, and giving them the tools that when they do return to the community to be successful, to secure employment, maintain jobs. And we have a number of people that came into our jail unemployed, substance abuse and behavioral health requirements. And when they left, their health was better than when they arrived. We maintained through a discharge planning employment, housing, the continuity of medical care, and maintaining their appointments with their behavioral health and substance abuse disorder counselors and peer support. This would not be possible without the great partnerships that we have with our community mental health team, our MyRep2 team, and obviously Wayne State, who's providing us all the statistical data to show our partners and our community leaders that these are valuable programs. So what's some barriers that we face? The DEA licensing. Years ago, we were able to retain and store these medications in a jail setting without any issues. Unfortunately, now the DEA has said you have to have a DEA license. I'm happy to report that we've built a good relationship and collaboration with the DEA, and they're, prior to COVID-19, they were helping us prepare a plan that hopefully all jails in Michigan would fall under the same plan in respect to being able to secure a license specific to jails and correctional institutions and eliminate a lot of red tape and barriers to getting that license, but most importantly, the cost. It's not an astronomical cost, but it's a cost, and we all know that some jails are better financially suited than others. So we wanted to get that to a point where it wasn't a barrier, the cost, to a facility unable to secure a DEA license. As I said earlier, COVID-19 kind of put a halt to that. We're confident that when we get back to normal business, whatever normal business is, that we'll be able to secure that license and set up a plan for the remaining 79 jails in Michigan to utilize or leverage that access to that DEA license. As I've mentioned throughout this presentation, our success stories evolve around our community collaboration between first responders, the community treatment programs, and the methadone clinic here in Monroe, and the memorandum of understanding between Monroe Community Mental Health, Passion of Minds, and we may even have one that involves our local EMS, so that when we do send a police officer or first responder to an overdose, we will immediately get that information as to the individual, whether they refused treatment, where they were transported to, if they were transported, almost on an instantaneous basis, so that we don't have to wait longer. And hopefully when they're at this location, we can dispatch our substance abuse team to address the overdose issue and get them help, as I mentioned earlier. I'm also proud to say that our MyRep2 team is issuing naloxone to our inmates that are in our MAT program, so that they have that in the event they revert back to their old habits. At a prior summit, I heard the example was given that substance abuse disorder is along the lines of a diabetic. Individuals that are diabetics will at times eat that candy bar. They will, for lack of a better term, fall off that wagon. And the difference between a substance abuse individual suffering from substance abuse disorder and that diabetic is the propensity for death is a lot lower. So having that naloxone available to those individuals that may reoffend or go back to their old ways, that they can save their life, and we can continue to give them the tools to be productive members of society. As I said earlier in the first part of my presentation, our community collaboration is our key to success. Again, parole, probation, our partners at Passion of Minds, Monroe Community Mental Health. Those individuals are just, the work that they do in our community, the continuity of services, their heart and passion, they have the passion to just move and help everybody in our community to succeed. I don't care what time of day or night it is, as we can call our team members and express to them a situation that we're facing, and they're always there to help. They don't just try to kick the can down the road or send us in another direction. And Adam and Tara, Lisa Jennings at Community Mental Health, I don't care who it is, They never tell us no. Even if it's outside their scope, they will get us in the right direction and give us the tools that we need. And I can't help but reiterate that the behavioral health partnership that we had with them is what led us to the success that we're having with the OTE grant and system. Again, we modeled our MAT program after our behavioral health, which was identify these individuals early on upon incarceration, get them the treatment and the tools that they need to maintain their care while they're incarcerated, and discharge planning that involves transportation, housing, and maintaining their appointments, and just giving them the support that they need to continue the service linkage. I already mentioned the Narcan distribution upon release from jail and case management going forward. Again, we continue to have success in our program because we collaborate. We meet, we talk daily about what we need to do to build the program, fill in those gaps that we have, and again, the data to support our decision-making process. I spoke about the post-overdose response model. We've shared that with other communities in Michigan, and we get positive results on that from what they're seeing as well. Also, when it comes to behavioral health, as we encounter individuals in the community, meaning we are first responders, of individuals that suffer from behavioral health that may not necessarily be on the radar for those at community mental health or other folks in our community, we have a referral form that we use. It's simple. It's a 3-line form with a small area for narrative. That is electronically sent to CMH as soon as the officer completes it. The officer then, or I'm sorry, CMH staff then reach out to the individual again within 24 hours to see what we can do to assist them. We've had individuals in our community that suffered from behavioral health. We had one particular female as an example. We responded to her home 42 times in 3 months with fire, ambulance, and police personnel. Once we put her into this program, we have not been back in over a year, we've not been back to her home. So again, we're proud of our partnerships with CMH. We look forward to continuing our partnership. So our future plans just consist of data collection and building that relationship with our partners based on statistical and analytical data, and continue to build our program for early identification, early intervention, early coordination for pre-release, and increased service options. So again, thank you for the time and the opportunity to provide this information. I know I shoved about 30 minutes of information in almost 15 minutes. So thank you.
Thank you, Major. We know you have a lot to cover for Monroe, so we appreciate you squeezing it all in. Joining us next is Nicole Skip, who has been working for a family outreach center at the Kent County Correctional Facility since 2011. She worked as a mental health therapist and jail diversion specialist before transitioning to supervisor of the Michigan Reentry Program and Opioid Treatment Ecosystem Initiative. Nicole uses her knowledge of both the criminal justice and social work fields to better advocate for the people she serves. Kent County's OTE efforts that Nicole will highlight today are also made possible by the Michigan Health Endowment Fund. Thank you, Nicole.
Thank you so much. Thank you for the opportunity to meet today and share with everybody what is happening in Kent County, and thank you for just the opportunity to provide treatment and resources to the clients at the Kent County Correctional Facility and the residents of Kent County in general. We'll start a little bit with just an overview. Kent County has a population of around 657,000 people. In our jail, we have just under 1,500 people capacity. And as of last week, our capacity was low due to COVID-19. It was just under 700 inmates currently. to better identify people who are at risk for opiate use disorder, anybody who is booked into the Kent County Jail is given the rods, and that's done by a nurse in our intake. And from there, we can determine who is at risk and what programs and services people will be eligible for in the jail. Currently, we operate a couple of behavioral health initiatives. One is jail diversion, and we also operate the MyRep 2 program, which I know the major highlighted a little bit about, and we'll discuss a little bit about that further on as well. Current OTE initiatives that we are offering, we are doing medications for opiate use disorder. In Kent County, we are offering Suboxone or buprenorphine and methadone. We are working on continuity of care for post-release, making sure that our clients are having good, solid release planning, and handoff to recovery coaches in the community upon their release. And then also the PROACT, which we'll talk about in further slides. As mentioned, we are using the rods as a screening tool to determine who is eligible for services and what services those may be. Also in the Kent County Jail, we have an internal alert system, and it's they're called O alerts, and they're based on an inmate's self-report of opiate use. So if somebody is booked into the jail and they report that they were receiving treatment for an opiate use disorder, they would be given an O2 alert. So we would follow them closely based on the medication that they're getting and the community provider that they're getting it through. If they were just reporting that they were using an opiate off the street but are not currently connected to treatment, they would get an O1 alert, and we would follow them a little bit different, try to connect them to services. And then an O3 alert is somebody that is connected to our drug court program in Kent County. So internally, we run reports daily based on those O alerts to determine who's currently in custody in our facility and how we can best triage and serve them. So for prevalence purposes, this was before the COVID-19 struck, and these numbers were based on our O alerts. We have an average of 60 to 70 people in our facility with an opiate use disorder at any given time. Of these people, most were actively using opioids in the community and were not on any sort of MOUD prior to coming into the correctional facility. And the average number of people who were getting medication prior to their arrest was between 17 and 20. Again, that was prior to the COVID-19 hitting, so those numbers have changed some currently. We do expect them, however, to increase once this COVID stuff hopefully dies down a little bit. So we're going to talk a little bit first about the PROACT and how Kent County is planning on handling this. So PROACT, proactive response to overdose and appropriate connections to treatment. So it's a community collaboration that Kent County's EMS agencies, the police departments in Kent County, and the RED Project. And for those who don't know, the RED Project is a nonprofit agency that their mission is dedicated to improving health, reducing risk, and preventing HIV. And one of the things that we are collaborating with them is to send out a recovery coach for non-fatal overdoses within, I think it's 24 hours, to connect people to services, just to check in, just to offer that support, to see if people are interested in getting, more thorough treatment, or just to kind of offer that support. So existing model, we currently have in Kent County a crisis psychiatric center that is utilized by our first responders to divert individuals in need of general behavioral health issues. So this is not specific to SUD, but it's behavioral health in general. And then we do have the RED project already connecting with people in the community following non-fatal overdose, excuse me. And so we're just going to build off of this in the future. So our expanded model is to continue to build stronger partnerships with our community partners. And we're going to offer better mechanisms to connect people to appropriate community treatment. So one of the ways is if the first responders are called to a non-fatal overdose, they're going to have these almost like a business card, and on it is going to be a QR scan, and they are going to scan that, and the information will be sent to the RED project, and it will have it will have the information necessary, and if the person who had the non-fatal overdose is interested, they'll sign a release, and within 1 to 2 days, a staff member from the RED project will follow up, and they can provide naloxone. They can train the client and family members on overdose reversal. They can offer harm reduction, recovery support, linkage to community services, and just kind of be an overall support and resource for the clients and their family members. As far as MOUD in the jail, I can speak a little more thoroughly on that, as this is something that I've been working on for several years, or working in conjunction with Network 180 and the jail staff. Liz, if you want to go to the next slide, please. Thank you. So we will have a case manager who will work with clients who are identified as having opiate use disorder in the jail, and they will be a family outreach center staff. Their office will be in the Kent County Jail, and they will meet with clients as soon as they're booked in and they're identified to begin discharge planning, begin discussing what services they're going to want when they get out, and not just specific to their opiate use. It's also related to housing, doctor's appointments, things like that. Really just trying to have some strong release planning set up so they are successful in their release. We will have a RED project peer support who will come in, start building rapport with a client while they're incarcerated, and then they will be the person who is providing the services, providing the outreach for the client. I believe it's for 12 months, and just making sure that their discharge plan is being held up. They're getting the services they need, they're making it to their appointments, their treatment is going the way that they wish, and just helping them navigate the systems of getting out of the jail, which is stressful in itself, and then adding an opiate use disorder or the desire to possibly use on top of that. So currently at the jail, we partner with Network 180, who is our community mental health provider, and we provide psychiatric medications for clients off of a formulary list. And we also have clients who come into the jail and are currently receiving methadone or buprenorphine are able to receive that while they're in custody. We are working on being able to have naltrexone. We were in conversation with that just before the COVID-19 hit, and so that's kind of been paused, but I anticipate that once we are all back to normal, conversations around that will continue, and hopefully we can get that set up soon. The Kent County Correctional Facility has a lot of treatment options available. We have a sober living unit on site for men and women. We have the MyRep 2 program available for clients who have an opiate use disorder or are at risk for an opiate use disorder. We'll again offer the OTE program. We have AA and NA groups. We provide MOUD as noted if clients are coming into the facility on MOUD. We have had a little bit of, like I said, pause due to the COVID-19 crisis. However, we anticipate that when things get back to normal, we'll pick up right where we were when we left off. Liz, if you want to go to the next slide. So eligibility to receive medication for OUD. Our goal is that in the future, anybody who is interested in MOUD will be able to receive that at Kent County Correctional Facility. We're not quite there yet. Our hope is that we'll begin conversation around that at the end of this year and into 2021. And then how many people have received MOUD since the OT implementation? I'm not exactly sure, to be honest, where the 10 people came from, because I know that we've have more people than 10 who are receiving MOUD at the jail. As noted in the earlier slide, there's about 17 to 20 who are currently on medication when the slides were made prior to the COVID. So at any given time, we have between, I would say, 15 and 20 clients who are receiving MOUD in the Kent County Jail. So for continuity of care, again, as the major talked about Monroe County, it's the same for us in Kent. It's just community collaboration and building strong partnerships. I work for Family Outreach Center. We provide the behavioral health services at the Kent County Correctional Facility and have for quite a long time. We are working again with the RED Project to provide both the peer support for clients who are getting out of the jail, as well as the PROACT peer support who will be following up on non-fatal overdoses. Network 180 is our community mental health provider in Kent County, and they support us and help us with referrals and are kind of our baseline for any sort of referral source in Kent County. Horizon Health is our medical provider at the Kent County Correctional Facility. So they are the doctors and nurses who are actually administering the MOUD. They are setting up drop-offs and things like that with the MOUD providers in the community. And then the community MOUD providers have been huge. So we have Cherry Health, New Point, West Michigan Treatment Centers are just a couple of them that we have been working with in order to ensure that the clients who are incarcerated are getting their medication. And then we'll continue to work with when clients are getting out to ensure that there's no gap in service, that the case managers are setting appointments for their clients so they have a specific place to go when their time is ready. So that is the big part of this is the discharge planning, making sure that clients have a seamless handoff from the correctional facility into the community and to ensure that there's no missed steps. So the case manager and the recovery coach having sound communication is something that is very important. As noted, for pre-release, there'll be a case manager who'll work in the facility with the clients, and then post-release, there will be a recovery coach who will work with them for 6 to 12 months post-release. So planning for unexpected releases, as we know, people who work in the correctional setting, that sometimes unexpected releases happen. And monitoring court dates and continued communication with the community partners and the MOUD providers in the community is huge. And we currently do this. We're monitoring court dates for people who are getting MOUD, and we're letting the community providers know, hey, look, there's a chance that this person may be getting out at court today. So there is sort of a emergency plan in place. And then we continue to discharge plan early to help alleviate some of the stress from the client. So if they are released unexpectedly, there are some plans in place. OTE clients will receive naloxone in their property at release. So when they are released from the jail, they will have a naloxone kit on their person. We do this currently with MyRep clients, and it's a seamless process, and it has been really helpful. So some barriers obviously have been COVID-19, along with every other agency and facility in the country. There has been an issue. We've had a lot of clients who have gotten out early, or who have, the census is just down overall. Non-essential staff are not permitted into the correctional facility currently, so all programming has paused. So that has been a barrier. But success is fewer inmates going through withdrawal at the jail because they're receiving their MOUD. Inmates are more motivated to continue their MOUD upon release because they have not gone through the withdrawal process, so they want to continue their services upon release. We're building strong relationships with our community supports, our recovery coaches, and our other community partners, advocating for clients, and ultimately the same goal is to see healthy clients. And then our innovative linkage with the EMS, the RED project through the QR codes at overdose reversal, we hope is huge and successful in linking people who may otherwise fall through the cracks to recovery coaches and services. So what's next for us in Kent County? We're kind of up in the air right now, just due to COVID. We're just kind of getting things in the swing of things. But as mentioned earlier, we want to assess the feasibility of new inductions at the jail at the end of 2020 or 2021. And sooner than that, hopefully, as we can get in the naltrexone, so we can start clients on that if they're interested pre-release. And then continue to connect people to treatment through the PROACT initiative, and diverting them from the criminal and legal system. So hoping to get them connected to services before they enter the jail, to keep them out of the criminal justice system. So we're excited for what's to come in Kent County, and we're excited for all of the progress that we have seen. And I just want to thank everyone who has been involved in helping us make this a reality. So thank you.
Thank you, Nicole. Heather Wiegand will be joining us next. She is the Clinical Services Manager for Health West, where she's worked for 7 years. In her previous role, she served as the first full-time correctional services liaison working inside the Muskegon County Jail. In her current position, Heather provides clinical supervision for the Access Department and Corrections team. She helped to resurrect and enhance the multidisciplinary team that makes up the Muskegon County Diversion Council. Heather has been part of developing teams and processes to improve treatment inside the county jail, increase opportunities for diversion in the community, and enhance the training and co-responding partnership among mental health professionals and law enforcement in Muskegon County. Welcome, Heather.
Thank you so much. I'm so excited to be amongst such stellar companies and programs. To get started today, I do want to also make sure to give a shout out to my team, which would include the clinical team through Health West, as well as the team at the correctional facility, Muskegon County Jail, WellPath, and the Public Defender's Office together, and the Family Outreach Center, which is the substance abuse provider inside the jail. Together, we make up the in-jail treatment team, and this would not be possible without all of them. In the county of Muskegon, we have almost 174,000 population, with that being the date from 2016. So we're hoping everybody does their census this year and we can get an accurate count again. Currently, the Muskegon County Jail has a rated capacity for 542, with 616 being our maximum capacity. We certainly, like everyone else, are experiencing less bookings into the jail at this time, as we are all experiencing changes in how we operate due to the COVID-19 experience. Currently in the jail, we do operate using the tools, rod, and K6 instruments. Initially, our program implemented that screening process utilizing our community health worker and a supports coordinator assistant. Both of those positions are funded by the Community Foundation Initiative and the application that we were funded from the Bureau of Justice. One of the interesting components of implementing those screens was that we partnered with the Public Defender's Office, and everyone who was seeing the public defender the morning following their booking was also seeing one of our team members to conduct those screens. Since the COVID experience, the booking officers are now conducting those screens for us, which has actually increased that 100% of those being booked into the jail are receiving the screen now. My hope is that the jail and us can work together to create 100% moving forward in some fashion. The medications that are currently being provided in the jail would include Vivitrol, Suboxone, and Methadone. We have a partnership with Cherry Health, which is the methadone provider in our community through the Muskegon Recovery Center. We are also providing continuity of care post-release, and largely this is happening as a result of our community health workers. We want to talk a little bit about how that booking happens, or excuse me, the screening happens at booking. Because we haven't had our opportunities to provide some training to our officers, we look forward to the opportunity to do that and improve on those responses. So far, we've been hearing some feedback that different officers doing that different ways. Some officers are providing the questions and then documenting the answers, while other officers are handing off the screens to the inmate. So we're working on some consistency in terms of how those screenings are occurring. We want to also talk a little bit about WellPath, our jail medical team. WellPath opted to not be part of the actual dosing for the medication in our jail. So we do have our supports coordinator assistant, who is also a trained medical assistant who is supporting that dosing in our jail. And when she is unavailable, the on-call nursing team from Health West is responding to the jail to deliver that dosing on an everyday basis. We worked with Cherry Health initially to establish the process for dosing, and we're doing a 1 time a day dosing for patients who are receiving MATs, both Suboxone and Methadone. So far in our jail, we have actually also experienced 38 individuals receiving the Vivitrol injection. That was through a different funding source than through the Community Foundation that was already in place when we were given the opportunity to expand the MAT in the jail. So we're very excited that we've been able to include the Suboxone and Methadone at this point. We've had 13 people who were actually given MAT so far, in addition to those 38 who have received the injection. Our in-jail treatment team is really leaps and bounds improving in the process of capturing those individuals quickly when they're first identified at booking. Our clinician is doing the GIPRA, sometimes the same day of booking, at least within 24 hours. Then we are connecting to our supports coordinator assistant, who is working to verify all of those outside providers. And then we're connecting to our own medical director and physician's assistant here at Health West to continue that maintenance of MAT in the jail. We are providing clinical assessment that goes beyond the K6 and ROD instrument. Part of this clinical assessment process is the result of our BJA project. And we'll be doing a full psychosocial assessment on a number of these individuals, along with trauma screening and treatment planning that will then follow them as they reintegrate back into the community. While they're in jail, they have the opportunity to receive individual and group therapy. We will always conduct crisis intervention, and making those community health connections to any provider that is going to fill a need for them when they leave jail. That discharge planning is an incredibly important piece. When we were asked about the eligibility criteria as to who gets to receive the MOUD in the jail, that was an interesting question from the beginning. One of the things that our sheriff wanted to make super sure of is that we were not missing people. And unfortunately, that has been one of our barriers. Because of methadone in particularly, we've been finding that individuals receiving methadone from primary care physicians for conditions of pain, we're not able to support them with this particular initiative. Additionally, we are concerned about those who are being treated at other clinics, and we're trying to make arrangements now as to how we can improve in that area. Partnering with other clinics and providers. We want to make sure to talk a little bit about the holistic defense program through the Public Defender's Office. We're fortunate in Muskegon to partner with a full-time social worker that's in their office, and she is really helpful in making those connections, referring to us, as well as us being able to reach back out to her as a liaison to the Public Defender's Office. Certainly, we all experience barriers as I wrap this up with the COVID-19 experience, but I want to make sure to give a shout out to Lieutenant Smith and his administrative team at the jail. We have done an amazing job of so swiftly implementing the telehealth services, using the iPad systems, using Zoom, and also using the Cisco phone system. This has provided us really not missing a beat to be able to provide individual therapy, risk assessments, and both psychiatric and MAT specific doctor's appointments in the jail. Our jail team has acted so quickly in making sure that these resources can be accommodated, and we're proud to be a part of such an amazing team. Our future plans, we hope to continue in expanding on the opportunities for medication. We hope that we can only escalate the opportunities for virtual services. We want to make sure to identify that when patients leave the jail, they have an access to an array of virtual groups at Health West, including Smart Recovery and other skill building opportunities. They don't have to be open to Health West or community mental health in order to receive those. We have a great partnership with the RED Project, and we are also providing the naloxone kits when they leave jail. And one of the things that is unique to our program, I think, is that we are also making sure that we're staying on top of people who have those co-occurring active treatment orders to sustain both their mental health and their SUD treatment needs, both in jail and when they leave jail. I think that's about all I have for this morning, and I appreciate the opportunity to be able to present just a little bit about what Muskegon is doing in this regard. Thank you.
Thank you so much, Heather. Next, we have Lieutenant Michael Coburn, who has been with the Jackson County Office of the Sheriff since 2006 and has been assigned to the jail throughout his entire career. In 2012, Lieutenant Coburn was promoted to sergeant, and in 2014, he was promoted to assistant jail administrator under Captain Bob Vogt. In addition to involvement in the Stepping Up for Mental Health initiative in 2018, Lieutenant Coburn is currently leading his team in implementing the full array of medications for opioid use disorder inside the Jackson County Jail, one of our first OTE communities to do so. Welcome, Lieutenant.
Good morning. Excuse me. I just want to take a second. It is National Correction Officer Appreciation Week, so if you see correction officers, thank them for their hard work and dedication to their career. I'm here this morning to speak a little bit about the medical assisted treatment program we have here at the Jackson County Jail and how it affects our community. We have a current population of around 160,000 Our neighboring counties are Lenawee, Hillsdale, Ingham, and Branch County. Our jail capacity is right around 400. We have 2 jails here in Jackson. Our main jail holds about 187, and the jail that I work at, our General Correctional Facility, holds about 257. With the COVID epidemic, we have dropped our population from about 380 down to about 200. Currently, we use the ROD's screening tool, and we incorporate that as part of booking. So we try to catch everyone right at the beginning of when they come into the facility. Everyone receives the ROD screening tool who is arrested. The only exception to that is those that arrested on immediate PR bonds. There really is no value in giving someone that's going to immediately bond out. Prevalence, 13% of all individuals booked into our jails screen positive for opiate use disorder. So we roughly book in about 8,000 to 9,000 individuals a year. So you're looking at anywhere from about 1,000 to 1,100 people that are positive for some sort of opiate use disorder that are coming into our doors. Currently, we use OUD in the jail. We're going to talk about continuity of care and post-release. Currently, our community collaboration, we have advanced correctional health care here at the jail. They are a medical provider. They work along with CMH and Lifeways. And then our mat provider that provides our medication is the Victory Clinic here in Jackson. Prior treatment, we had very minimal treatment actually. We had AA and NA and access to naltrexone was available upon request. We really jumped at the chance when we were approached with this opportunity. We felt it was going to be a positive experience for everyone here, and it has been a wonder since we went to started this whole experiment. Expanded treatment for OUD in the jail. Continuation of all 3 forms of MOOD or MOUD for individuals with an active prescription in the community. Those who choose to continue their medication will also soon be provided with access to OUD targeted individual group sessions. Expanded discharge planning services. And plan to incorporate these same services for others. Available medications for OUD, we use methadone, buprenorphine, and naltrexone. Currently, we are funded all through grants, which we hope will continue. Eligibility criteria for MOUD. Currently, only individuals with an active community prescription for MOUD are eligible. We will also have our doctor fill out prescriptions, and we'll go from there. Currently, we have about 13 people that have been in the program. Obviously, with the COVID epidemic, our numbers have gone down. And we've had as many as 7 at one time, which is quite a number for our population. And we've seen just a enormous value in that. Implementation, so there's a whole team of people that work together. Or we have our correction officers who start the process that will hand off to our CMH. We have 2 CMH workers that work in the jail 80 hours a week. Our jail medical will be alerted, and then they will go through our nursing staff and our doctor who will write the script, and then our community provider will write excuse me, our jail medical will write the script, and then Victory Clinic will distribute the medication. Our incorporation of a validated screening tool, like I said, we use the rods, and it's worked very well for us. And then we have access to all 3 forms of MOUD. Next screen, please. Like I said, our involved agencies are Jackson County, or the Jackson County Jail, CMH and Lifeways, and our community MAT provider is Victory Clinic. Seems to be a seamless process. If there is any issues, their communication is very fluent between all 3 agencies. So if we do have problems, they were able to work it out with very little issues. One of the things that we really wanted to focus on was discharge planning. Wanted to make sure that those individuals who were getting care in the facility were still getting the care once they left. So Lifeways and Victory Clinic will continue their care once they leave, and we've seen success in that area. They have case coordination, meaning that they're going to follow these individuals and make sure that they are staying and coming to get their medications once they do get out at the Victory Clinic. Making sure that they're dosing upon release, and that they stay within Lifeways, and to make sure that they are getting that that recovery coach aspect once they do leave. Next slide, please. So our connection to community providers, like I said, Victory Clinic is who we use. Excuse me. Sorry, my screen went blank. I apologize. Unexpected releases we haven't had an issue with that, being that we just had the COVID epidemic and released roughly 200 inmates. Everyone has seemed to have been continuing their care and their follow-up, which has proven that this program does work. One of the surprising outcomes of this program has been, before here in Jackson County, we did not have a very solid treatment program. But now that word has gotten out on the street, and a lot of these people that did have warrants, knowing that they were going to be coming to jail and trying to avoid that, will now turn themselves in, knowing that we do have this in place. So it has been a very positive on the community itself, knowing that those who were afraid because they didn't want to go through withdrawals can now come here knowing that they will get the care that they need. Next slide, please. So with the COVID epidemic, we've had to figure out how to continue treatment. One of the ways is obviously we're going to start using telehealth, so we can have that aspect into the jail. We understand that there's been roadblocks, and we're trying to work through them, and hopefully that telehealth will help us overcome that. Distributing naloxone to not only those who receive jail-based mode, but also to anyone who screens positive for OUD. And partnering with recovery housing developments to enhance continuity of care upon release. Community-based response to non-fatal overdoses. The CBHJ has initiated communication with local EMS leadership regarding the possibility of evaluating response to non-fatal overdoses and corresponding connection to services.
Thank you so much, Lieutenant Coburn, for your time today and for sharing that wonderful information with us. Next, we have two presenters from Washtenaw County to share their plans for expanding their treatment ecosystem, and that is Renee Wilson and Lisa Gentz. Renee has spent the last 22 years working within the corrections field, both inside correctional facilities and through community corrections. She's been the Director of Community Corrections in Washtenaw County since 2009, and in 2015 also assumed the position of Director of Correctional and Reentry Services for the Washtenaw County Sheriff's Office. Through these roles, Renee is responsible for overseeing all alternatives to incarceration programs, pretrial services, jail programming and services, population management, and has worked to design, develop, and implement a reentry program for the Washtenaw County Jail. Lisa Gentz is a licensed social worker and the program administrator for millage initiatives, mental health court, and jail services teams for Washtenaw County Community Mental Health. As a mental health professional for the last 18 years, Lisa has worked extensively with individuals with the most severe and persistent forms of mental illness, centering primarily on the delivery of crisis care. Most recently, Lisa's work has focused on developing law enforcement and mental health collaborations, training first responders on managing mental health crises, and developing creative community strategies to address behavioral health treatment needs. Thank you so much for joining us today, Renee and Lisa.
Hello, thank you.
Thank you. Thank you to the Center for putting in the hard work to put this summit together and being flexible and very adaptable to moving to an online version so that we can still have conversations about this important topic and share information and work together as communities to learn from each other and move forward with addressing the opiate crisis in the state. So thank you. Next slide. So Washtenaw County is a primarily urban county with about 367,000 individuals. We have a jail capacity here of 404 beds. Our average daily population pre-COVID was running around 330, 340. Like many other county jails, when we were faced with the COVID pandemic, we dramatically reduced our jail population. I believe our count as of this morning was 133 individuals. We have a few different initiatives that we've been working on over the last few years, specifically around jail diversion, but also stepping up. We had in 2018 a public safety mental health millage that was passed in this community that we'll speak a little bit more about in a few minutes. And those together, those initiatives have really kind of pushed us forward in addressing some of the mental health and substance use issues we see in the community, but more specifically, allowing us to really take note of and address those issues internally within the criminal justice system and as law enforcement as well. So currently we're using two different types of screens in our county jail, and these screens are done at the time of booking. They are the TCUDS and the GAINS screen to both identify substance use disorder as well as mental health. We were actually in the process of training staff and transitioning over to RODS and the K6 when the COVID pandemic hit us. So that has been paused, but as soon as our jail operations are back open and we're able to get non-essential staff back in to work alongside our correction staff, we will get the K6 and the RODS fully implemented, and then those will replace the TCUDS and the GAINS. The prevalence for us in our jail of all of the individuals who have engaged in some sort of substance use assessment or screening, or have been engaged by one of our partner providers to receive some sort of substance use treatment while in jail, between 30 and 40% of those individuals have an identified opiate use disorder to some extent. And currently, we are using medications in the jail. We are using the naltrexone, Vivitrol, and naloxone options. We are in the process of implementing the methadone and Suboxone, buprenorphine processes in our jail as well. And we have a rather extensive continuity of care post-release partnership and discharge planning process that we use for all of our individuals in the county. So our primary community collaborations obviously is with community mental health. My partner, Lisa Getz, is here today as well. She'll be sharing some information, but really everything that we've been able to do to address the substance use and mental health issues that we see locally in the jail, but in the community, is really based off of the partnership that the Sheriff's Office and our community mental health has. And we really work in tandem and partnership in everything that we do inside the jail and in the community. And that has really just expanded the opportunities for us to really engage folks that might not have otherwise engaged in services with law enforcement or community mental health, but also allowed us to really kind of engage service providers in the community that were at one time maybe working more in a silo type of arena, and really kind of expand collaboration and partnership through that. So we also partner with WellPath. They are our medical provider in the Washtenaw County Jail. We have Dawn Farm and Home New Vision, who are substance use providers in this community. They do extensive work with us inside the jail with our population and through our reentry team and discharge planning. And then we have a direct connection with Packard Health Clinic to really support all of our medical assisted treatment programs or individuals who are engaged in those post-release. While they're in jail, we have a rather extensive substance use treatment programming with a multi-level of care depending on where the individual is in their journey to recovery, as well as what their needs are. We do start individuals on naltrexone and Vivitrol when they're in jail, as well as connect them to continued care in those arenas post-release, or at least get them started post-release if they choose to wait until they're out to do so. We have the naloxone kit program. So we have naloxone kits that go in everybody's property bag prior to release. And as I mentioned before, pre-COVID, we were in the process of writing our policies to bring methadone, buprenorphine inside the jail and expand our OTE that way. So as I mentioned, currently naltrexone and naloxone are our medications that we use, and everyone is eligible right now based off of our model that we've put in place. So anyone who is identified through our community mental health team, our substance use provider team that's in the jail, our corrections staff, our medical team, who wants to engage in conversation and really explore the option for medical assisted treatment, we will sit down and do so with them. We have a partnership with our providers through CMH that will actually do an assessment with these folks and get them started and connected if they choose to continue down that path. And since we started really with the naltrexone and Vivitrol a few years ago, we've actually put between 100 and 150 people have either started on the naltrexone Vivitrol in the jail or have had a solid treatment plan ready and prepared for them as part of the larger discharge reentry services through Packard Health upon release. Currently, we are getting our medications through our partnership with Community Mental Health. A large amount of the medications that we're bringing in are through their program and their access to those through their prescribers. But we also at the Sheriff's Office are committed to this form of a treatment program for individuals. And so we fund part of those medications as well.
So a little bit more about some of the secrets to our successful program in Washtenaw County. I will echo what Renee has said. Really, a lot of what we've been able to do has been the result of strong community partnerships that we have in the services that are being offered in Washtenaw County Jail, as well as are able to be continued into the community upon release. So Community Mental Health provides all of the psychiatry clinic medications and mental health support and diversion initiatives going on currently in Washtenaw County Jail, as well as our two primary substance use disorder partners, Dawn Farms and Home of New Vision, who also provide extensive services. And we've really seen the impact of these partnerships in making sure that we have continuity of care and smooth reentry for individuals. We're currently in the midst of expanding our treatment options beyond the naltrexone, Vivitrol, and naloxone into buprenorphine and methadone. and had met with some providers that we wanted to, we were looking to develop MOUs with, and then COVID came along literally the week after we met with that provider and had set up a tour for them to come and see what it is that we do. Continuing these conversations and hopeful that we can have an MOU in place soon, so that when we're able to expand, we'll be able to get this all up and running quite quickly. Again, some of our success with implementation is, the strong support that we have from our sheriff. He is dedicated to ensure that we are doing the right thing for the people in our community, and MOUD is absolutely part of that, as well as our commitment to ensure that meaning community mental health commitment to ensure that we are partnering to meet the needs of the individuals. It has never been lost on us that we recognize that so many people in our community end up in the jail receiving their behavioral health services, and we really want to change that locally. Another big secret to our implementation success is our partnership with Packard Health. Packard Health is our local FQHC and is a really safety net physical health provider in Washtenaw, but also provides MOUD in our community. So when we initiate anybody in these services, we start our discharge planning and coordination with Packard Health immediately as soon as they consent for treatment. You can flip to the next slide and I can continue talking a little bit more about that partnership. So as soon as they consent for medications, we are contacting Packard Health, and we have a single point person on their side that we connect with to start establishing services, as well as connect that individual to a peer support specialist, so that we can identify and quickly remove any possible barriers that might be in play for follow-up care. One of the other things that's really nice about the current situation that we have is that Packard then can, though we're only offering the naltrexone and Vivitrol at this time, they are able to quickly switch people upon connection and release to additional MOUD offerings currently, but we're excited that we won't need to have that be the case very soon here. But we've seen that there can be many barriers that come into play for people getting access to that follow-up care, and we're working very hard to try to eliminate all of those barriers through our reentry efforts. Again, we put naloxone kits in to people's property bags, so they have those upon release. We are also looking at how we can increase our coordination efforts for unexpected releases and see this as a significant opportunity for growth for us in our current expansion. But one of the things that we have been able to do, we are very fortunate to have received a mental health and public safety millage, which has provided a lot of flexible funding in our community to address not only the mental health, public safety, but substance use disorder needs in Washtenaw County. This has allowed us to create a team called our CARES team, which is available to anyone in Washtenaw County. Yeah, you can go ahead and flip the slide. Thank you. And this team has a whole host of peers, case management, psychiatry, support, and they are really able to be called up to initiate care and treatment for anyone that's in the jail, and then follow them into the community for up to 12 months post-release. So they have been a huge connector and somebody that has helped us with our reentry efforts. I'm just checking to see if there's anything that I may have missed. One of the things that we hold very dear here in Washtenaw County is related to our stepping up in diversion council initiatives, which is tracking data. We're still using all of our data to ensure that we are identifying where our gaps are, identifying strategies that are data driven to be able to ensure that people are getting the services that they need. We identified that if we could reduce recidivism, 180 days post-release, we saw a significant drop in those individuals ever coming back to the jail. So we're trying to develop all of our strategies around how we can create a wraparound approach to support individuals in the most comprehensive way so they don't ever have to step foot back in Washtenaw County Jail. Next slide.
So what's next for us in Washtenaw County? Obviously, you heard us talk about expanding the medications to include the methadone and buprenorphine. as well as getting the rods and the K6 up and running officially to replace the TCUDs and the gains that we're currently using as part of our screening and booking process. We're also looking at redesigning our substance use disorder services that we offer in jail to provide an expanded recovery model and peer support program for individuals who engage in our services. For our sustainability, you heard Lisa and I both mention the public safety and mental health millage that we have in this community. That is really going to be the foundation for us to continue to do some of the future work that we have planned, but really be able to allow us to continue to meet the needs of our community and the people that we see inside the jail. Our community-based response to overdoses, we talked about the naloxone kits that we provide, providing community education and programming. We do also have the ROOT program. You've heard a couple other communities talk about that team that is initiated when there is an overdose in the community that meets with the individuals at the emergency room and is able to try to engage them and connect them to services kind of at that most vulnerable moment. And so we're really looking at how we can take our existing ROOT team or approaches to those overdoses in the community and really kind of expand it even more, provide additional services and supports long-term for individuals that we come in contact with.
Thank you so much, Renee and Lisa.
Thank you.
To wrap up our county level presentations today, we welcome Darlene Owens, who is the Director of Substance Use Disorder Initiatives for the Detroit-Wayne Integrated Health Network. Darlene's professional experience includes 29 years in the human services industry, with 23 of those years spent in administration. In her current role, Ms. Owens oversees the delivery of substance use prevention, treatment, and recovery services for the Detroit and Wayne County area. She ensures that her network meets all contractual requirements, that services are consumer and community focused, are aligned with best practices and evidence-based methodologies, and are driven by data. Darlene's experience in program development and evaluation of outcomes makes her a champion for expanding the opioid treatment ecosystem in Wayne County. Welcome, Darlene.
Hello, everyone. Ready for the next slide. Thank you for having me here. So Wayne County is 1.7 million. It's urban. We've had a lot of previous CBHJ initiatives, and some of them I didn't put down. My rep, that's something that we have going on right now with the Detroit Reentry Center as well as Huron Valley. But also we had a jail diversion program back in the day, and Stepping Up. We used to have that program, but now it is called the sequential model that we're doing. Some of the current OTE initiatives that we're doing is medications for our OUD in jail. We have one that started with our Dickerson program, and that was when we were just administering Vivitrol. And when the Southeast Foundation came and approached us about a grant, and we're so happy to have it, in Wayne State University, who rocks. Basically, we expanded that to all 3 medications. Now, as you know, due to COVID-19, all of these operations are suspended at this moment, but we've made a lot of progress, especially with the first one that we initiated in Wayne County Jail, Dickerson. Continuity of care post-release. Yes, we're doing that. We're doing that 90 days after someone is released, and we're still following up with them with our peer recovery coaches, and we're trying to keep them engaged. And I have to say, to this date, we still have 5 of those individuals that are in medication-assisted treatment programs. The jail capacity is 29,000 plus. The screening tools that's used in the jails is the K6 and the cows, and I believe we're going to start using the rods. Who receives screening to anyone who books into the jail. So anyone that wants to help, we want to help them. The prevalence is K6 data, 15% of all books reported opiate use in 2019. Next slide, please. And I talk fast, so I apologize. Some of our community collaboration partners is Wayne County Sheriff's Office, the jail, Detroit Wayne, that's us, Integrated Health Network, Hagera Health Incorporated, Quality Behavioral Health, and I have to say also our community partners are Wayne State University, who is a great partner to have. Some of the different state treatment services that are available for OUD is peer support and provision of 3 medications, primarily naloxone. That's the first program that we started out with, was using peer supports to actually get the clients and the inmates involved to come into treatment services. Now with the new program, we're using master's prepared clinicians to do that individual group counseling and crisis intervention. And again, they're using all 3 medications. And also those peer recovery coaches. We find that peer recovery coaches are invaluable to use. They know exactly what the inmates are going through, and I'm sorry if I say clients, but the inmates are going through, but they can actually reach them. The expansion of the treatment ecosystem. 89 inmates are receiving peer support services, MOUD services in connection to the community providers post-release. So when they're coming out of the jail, our folks are there waiting for them. We're going to try to either keep them engaged with the providers that they're working with, or either we have an array of services that they can actually reach out to. We do not want anyone to fall in between the cracks. The continuation of medications with the same post-release with option to switch to another provider within DWIN's network. So right now they're working with 2 providers, that's Hagera Health and Quality Behavioral Health. They can actually work with them, stay on their medication assisted treatment, but if not, we have several others that will be available as well. Next slide, please. Again, naloxone, buprenorphine, methadone, those are the medications that we provide. DWIN pays for the medications. We pay for it, give it to our providers. The providers use their medical doctors that actually prescribes the medications. And WellPath, oh, and that's one of our providers too that I forgot. WellPath is one of our providers that administers the medications while it's in jail. Consumers must be an inmate at Dickerson Detentional Facility, Division 3, or the downtown facility, Division 1. And that's our women's facility. So that's a new one that we're adding on. Must self-identify as having an opiate use disorder. If someone says that they have a problem, we better answer that call. We have served 89 inmates are receiving peer support and MOUD services. 27 folks were released post follow-up, and 5 are continuing in medication assisted treatment providers with our MAT services. And we're currently planning on implementation of OTE related MOUD services. So this is something that we think is something that's needed. It is something that we're going to continue to provide. So that I do have the support of our Substance Use Disorder Oversight Policy Board. Next slide, please. Some of the barriers to implementation, obtaining buy-in from the jail administration and medical staff. It was kind of hard in the beginning to start the services. No one wanted to go get inmates, hard to get them on the phone, that kind of stuff. Inmates' willingness to receive naloxone. So, you know, it was something different for them. But again, those peer recovery coaches helped out a great deal. It was difficult to continue with follow-up services with early releases. We had to do a lot of different changes, had to put some discharge planning in front before people were released. It was challenges with peer support specialist referral process. Again, trying to get those referrals. It was hard and limited with technology. And that's something that we're working on with Wayne County Jail. So we can start providing telehealth services once we can get back into the jails. Implementation success, increased referrals to recovery coaches, improved identification of MOUD eligible participants, expansion of referral lists, initiation of naloxone, distribution of naloxone kits at release. It took a few meetings with the jail staff to understand what we're here to do. We're here to help. We're a partner of theirs. And once that got going on, everything changed. 111 inmates at William Dickerson Detention Facility in Hamtramck were served at the jail-based OUD program. Peer recovery coaches services were provided. Medication for opioid use disorders, naloxone training and distribution of kits, post-release follow-up support. 5 consumers have enrolled in MOUD programs. We started training the Wayne County jails on how to reverse an overdose a while ago. We made sure that we had Narcan kits on all of the floors, but definitely whenever someone leaves that have an opioid use disorder, they are trained on how to use it and that they have a kit with them. and how they can also get another kit if they utilize it. Next slide, please. Again, our community partners, and I didn't put down everyone: Hagera Health, Quality Behavioral Health, Wayne County Health and Human Services, as well as WellPath for providing the medical services, as well as Wayne State University. So I do apologize, you guys. Enhanced discharge planning. Consumers created a person-centered aftercare plan with a peer support specialist in the jail, development of the recovery plan, selection of an aftercare provider, because we do not want to lose anyone. We want to make sure that they stay engaged while we have them. Warm handoffs to another provider or election to continue peer support services to the jail-based MOUD provider. Again, we provide those naloxone kits to all consumers who request a naloxone kit, and they're trained on it, given once they leave the MOUD program. And I have to say, this is being very successful, that folks are utilizing those Narcan kits, so we're very proud about that. Following along, services offered by the jail-based MOUD provider for 90 days post-release. Those peer recovery coaches are fabulous to work with. They actually keep the clients engaged, know what's going on with them. And if someone does want to come back into treatment services, if they do not stay engaged, we're there for them. Something else that we're going to implement as well is the use of our mobile care units as well to help us out with engaging our folks and keeping them in. And hopefully the rumor is that possibly they may start providing medication assisted treatment on the mobile units. Some of the unexpected releases begin discharge planning early. We had to do that so that way we can make sure that we keep those folks engaged, or either keep them with that MAT provider that they're utilizing. Sign releases for all service providers. So we wanted to do all that in the beginning. So we wanted to do discharge planning in the beginning instead of waiting till the end. Next slide, please. Expand access to MOUD. DWIN is encouraging all of its SUD providers to provide MOUD services to expand treatment options and reduce stigma. We found that if you're having substance abuse services in a hospital or in a provider's office, that takes away from stigma. So that way you don't know if that person is going there for medical services or if they're going there for MAT services. So we're working with 2 OBOTs in Wayne County. We hope to get more. We're actually encouraging and have expanded MOUD services with our traditional outpatient centers. Again, you don't know if they're going there just for mental health services, what have you. We even have some programs, not MOUD in our churches, but we are working with our churches to provide that faith-based component, but also to take away that stigma. Providing naloxone kits at release. We have an aggressive campaign that is going on in Wayne County with getting out those naloxone kits. So that's something that we find that's very important to do. Sustainability. DWIN will continue to fund this program. We find that it's valuable. Our SUD Oversight Policy Board supports us on it. We are currently pursuing all kinds of different grants to keep this sustained. We're hoping that it will stay sustained, as we've applied for various different ones, and we believe that it's going to be successful. But also we have our SUD Oversight Policy Board that has funding as well that's available, and they believe in this. We believe in helping those folks that are returning back into their communities to stay in treatment, to stay well. We believe in a holistic approach, and this is something that we stand behind. Response to non-fatal overdoses. Again, our mobile care units, they provide follow-up for us. They're getting ready to do a lot with the COVID-19 pandemic that we're facing now. We wrote a grant that we received, so they're going to be helping us out with needle exchange, passing out PPEs into the community, and following up with our clients. And also, if it's someone that is on the fence about coming into treatment services, they're going to actually try to do an aggressive outreach. Using our peer recovery coaches, we have 199 certified peer recovery coaches in Wayne County, and we have them out there working to keep people engaged, to keep our eye on the prize. That as Ray stated, that our opioid use disorder, Brad stated rather, that our opioid use disorder, yes, they're going to go up, as well as cocaine. We see that increasing in Wayne County, so we have to stay on top of it. We're going to revise our strategy in light of COVID-19. We have right now currently some COVID recovery homes for those folks that test positive for COVID as well as have the signs and symptoms. So we have some things in place. We're promoting telehealth every kind of way that we can. And again, like I stated, we will be working with the Wayne County Jail to get telehealth up and going so we can continue these programs. So we're moving and we want to keep them going. Next slide. Thank you.
Thank you so much, Darlene. At this time, I really would like to thank all of our presenters from Monroe, Kent, Muskegon, Jackson, Washtenaw, and Wayne counties. As a reminder for attendees, we will have a few minutes for Q&A toward the end of the event, so please enter your questions for panelists in the Q&A box if you have not already done so. Next, we will hear from Matt Costello, who joined the Center for Behavioral Health and Justice in July 2019 to provide leadership for the Opioid Treatment Ecosystem Initiative. Prior to joining the CBHJ, Matt worked within the Program Services Unit of a large Metro Detroit jail for 29 years, supervising the unit for 19 years. With a deeply held commitment and passion for serving the most at-risk groups of people that encounter our criminal legal system, Matt's corrections-based knowledge, social work background, and expertise in building partnerships provides a unique perspective on how to design, implement, and assess jail-based services. Today, Matt will share the key components that communities should strive for in order to implement a full and comprehensive treatment ecosystem.
Thank you, Nicole, and I appreciate the introduction. I want to, again, extend a thank you to the Michigan Health Endowment Fund, the MDHHS, and MOP for carving out these opportunities to bring our communities together to share these experiences and the knowledge that we all have. I also want to extend a thank you to the corrections officer in honor of today's National Corrections Day, as well as a shout out for National Teachers Day, because I know many people are teaching at home. So again, welcome to everybody. My focus here is really looking at, as Nicole was describing, what are our next steps? How do we kind of move these processes forward? Looking at it from a total ecosystem perspective. So looking at the PROACT model to begin with, then moving into MOUD and jail, and then our communities of practice. Focusing in the PROACT model, we really want to look at it from a micro and macro level. So from a micro level, we're really going to be working with our initial communities, Kent and Monroe, and looking to gather the data necessary to make sure that we're reaching the goals and that we want. So we found in our investigation that the first responders, EMS, fire, and police had low connectivity with the harm reduction agencies in the community. So through facilitation of meetings and discussions, we've found a way to create that connectivity with those provider agencies, with the first responders. Our hope is then that we start gathering the data from our first responders to our harm reduction people to increase the amount of referrals that our harm reduction individuals are experiencing, so they can reach out to more people. Previously, harm reduction contacts were limited to the individual themselves or an interested party reaching into the community for treatment. This kind of bypasses that process. We saw some discussion about PROACT before, particularly in Kent County, and we see displayed a red project business card that's being handed out by all our first responders. In Kent County, a similar model is being developed in Monroe County, where not only the individual that's at the save, but any other people standing by will be provided these particular cards for access into the harm reduction networks. We're also looking to see and shorten the response time from our harm reduction partners from the time of notification of the overdose save to the contact with their peer support specialist to see about an engagement in treatment. So again, shortening that window, because we have that teachable, reachable moment that we want to get in touch with individuals to try and connect them into treatment and see if we can have some successes that way. We're also then going to try and monitor or evaluate an individual's response to treatment. Did they go into treatment? At what level did they accept the treatment? How long were they engaged into the treatment to kind of determine whether the effectiveness of the program. Gathering all these data points together, we would then obviously produce some reports back to our stakeholders in the PROACT model, so all the decisions can be made from a data driven kind of perspective. That's really at the micro level. At the macro level, again, the Center for Behavioral Health and Justice believes that this has an opportunity to be expanded to additional sites, as was mentioned earlier. We are in the process of expanding the third site, and we believe that it has applicability to be expanded to many counties throughout the state of Michigan because of its value and its expedient process by which we're connecting the first responders to the harm reduction people, to the people who need those kinds of services the most. The other part of PROACT, I think, also has an opportunity to be expanded beyond just the overdose save potential. We've heard from some of our communities that they already have some plans in place, but where they can use them for, say mental health emergencies, other kinds of first responder kinds of interactions that the individuals are having, to then connect them with treatment in a much more expedient and beneficial fashion. So that's really on the micro level of where we're at, or the macro level for the PROACT. Transitioning then into what's our next steps, or where we're moving for our MOUD in the jail. We continue to work primarily with our counties right now on early identification, because that is really the linchpin by which MOUD services are dependent upon. We are going to make sure that our sites stay fidelity to the program, to the model of MOUD. That means that they're prescribing or have availability of all three forms of medication: buprenorphine, methadone, and naltrexone. We also want to see the evidence of behavioral health services, both individual and group. Having a medication-only program is not a best practice model. We want to see the concurrent behavioral health services to go along with that in a specialized way through their clinicians that they're having into their program. Our sites have done an exceptional job in identifying those who were involved in MOUD program prior to incarceration, and starting those individuals in services as soon as possible into the jail incarceration. What we're going to be pushing for as a next step there is that we start moving into new inductions of individuals who would benefit and need MOUD services. They were opioid involved prior to the incarceration, but not formally in an opioid treatment program. So we're looking to have our individuals, our sites, create more service opportunities and inductions for new people into the discharge, into the program. The second element, all the programming in the jail, behavioral health and medication is fine, but if there's no corresponding discharge planning going on for expected and unexpected releases, as well as out-county participants. So each of these variables require us to continue to monitor with our partners and stakeholders in these communities about how are they managing the unexpected releases, and how are they managing people who are out-county residents and returning to their county of origin when they are released from the jail. We're going to, again, from a micro level, looking at establishing, making sure that appointment dates and times are set with a community-based relief provider prior to their release into the community. As we've heard from most of our communities already, but we're going to, again, make sure that this kind of stays in place, and it would be a best practice model for future sites, is that naloxone kits are provided to all OUD involved individuals at the time of their release. We'd even like to see that expanded, that the naloxone would be administered or offered to anybody upon request, whether they are OUD involved or an MOUD involved in the jail or not. So we're looking for that continued expansion. Again, we're looking to continue to receive and evaluate both aggregate and individualized level data from our counties to determine the effectiveness and the reach of their programming, to see if the goals and the model is being adhered to, and to present that information back to them in a way that helps them kind of look and examine their own systems. We've mentioned a couple of times here, but again, the use of telemedicine in this COVID-19 environment with the pandemic. We see great value in the opportunity to provide the telemedicine opportunity for the conducting of initial evaluations, medication reviews, discharge intakes and appointments. These are specialized services that would be beneficial to people as they are, since restriction to the jails are to essential staff only. Our providers then can use telehealth to initiate services or continue services, or better plan for discharge for services for individuals who are leaving the facility. So again, we see telehealth and telemedicine as being a great tool to utilize during this time of pandemic and reach out. Transitioning then to the community of practice model, again, and on a micro level, and probably the most important one is trying to, working to expand MOUD to all the other jails in the state of Michigan. Again, the lift that our 6 counties today have done or are doing as it relates to starting MOUD services inside the jail is tremendous. We believe this to be a critical care, chronic care condition that jails need to be responsive to. So we're trying to encourage and engage other counties to begin MOUD services into the jail. I have just a couple more things to talk about in terms of the community of practice. We're trying to stay true to our timelines here. So again, the community of practice models, the CBHJ is going to produce webinars for our community of practice stakeholders on topics that our stakeholders have identified. We're going to continue the policy briefs again on issues and topics that our stakeholders have identified. The use and expansion of telehealth medicine for standardized instruments. We can download the rods, the K6, what other kind of instruments for our sites to kind of make those processes easier. And we also want to expand our community of practice partnership to our PROACT partners. So, creating a larger tent for more participation in our community of practice module. So that was a very quick run through. I'm sorry, but I'm trying to stay true to time. And I'm going to turn it over to Ronnie for our Q&A session. So thank you.
Sure. Thanks, Matt. Good morning, everyone. My name is Ronnie Kason, and I'm a project coordinator for the OTE initiative in Jackson and Washtenaw counties. And I will be facilitating the question and answer portion of the agenda this morning. Throughout the duration of the summit, we've received some really great questions. However, we are running a bit short on time, so we'll only be able to address a couple of them now. And then the CBHJ will additionally compile those unanswered questions and answers and distribute them to attendees. Oh, sorry, I lost my notes here. As soon as possible. To begin, we received a number of questions regarding the distribution of naloxone upon release, so I'd like to address that question first. And I'd like to direct it to the Center Director, Brad Ray. So the question is, what is the decision to provide naloxone at release versus naltrexone? Providing naloxone seems to be condoning substance use, whereas naltrexone would block the high if they were to use.
So this is Brad here, everybody, Dr. Ray. I'll just concisely say that there's absolutely no empirical evidence whatsoever that providing naloxone to individuals increases their substance use behavior. So it's a perfectly safe substance to use, and it can be used to reverse an overdose, and everybody leaving jail should at least have it or know where it's at. Naltrexone, and I think this is another important point, since the middle of 2019, there's been a series of comparative effectiveness studies that have consistently shown methadone and buprenorphine to outperform naltrexone. So while it is a substance for some individuals that they may prefer, it does have side effects. And so it is not appropriate for everybody on exit. On naloxone is. So I'll just kind of drop the answer there and let you move on to the next question, Ronnie.
Thanks, Brad. The next question it's kind of two-pronged and it's a little long, but I'm going to direct it at Major Goodenough. In your opinion, are our jails truly equipped to handle individuals with OUD? The individual asking the question also notes that they have seen news stories of persons who have experienced opiate withdrawal while in jail custody and did not survive. What is being done to prevent this from happening in the jails?
All right, thank you. And again, I'm sorry, my computer died, so I had to transition to my phone and my computer. But to answer your question, when jails were designed or built, they were not built to deal with behavioral health or substance abuse disorder. However, I think the Sixth Circuit Court has made it very clear that if you don't treat these folks with medication-assisted therapy, deliberate indifference applies without question. So to answer the question, one, that's why you have to, in my opinion, you have to do a robust screening process, identify these individuals early on, and work with your healthcare provider and your substance abuse disorder, or as in our case, passion of minds in the community, to develop a plan to address these issues so that the grave consequences don't happen. And again, I think if they do, you're just exposing yourself to liability. And for those that know me from Wayne State, no is not in my vocabulary, or I can't. So you can achieve high things if you work together collaboratively.
Thank you, Major. I'm really trying to be mindful of time, so I'm just going to ask one more, and again, we'll compile these questions and answers and distribute them. So this last question I will direct to Renee and Lisa of Washtenaw. How do you measure the success of your current MOUD program? With the plan to add additional MOUD services, will that measurement of success be adjusted or modified?
So Lisa, I don't know if you want to take that or.
Oh, sorry, I was muted.
That's okay.
Yeah, no, well, we do a lot of tracking of our data, and what we've been able to identify thus far is even with our limited offering, we've seen a tremendous amount of success regarding the recidivism. So our diversion council has a data subcommittee, and we compile all the data for these individuals from our community mental health side, so their behavioral health data, as well as their charges, booking data, all of that information, and really look at the impact that this program has had thus far. And what we have identified is that those individuals, and Renee, please feel free to add in here as you see fit, but those individuals' recidivism that we've gotten involved in this program and connected to our FQHC Packard Health, we've seen their rates substantially decrease. And so that is showing us that we are headed in the right direction, and we expect that we will continue to see success, and if not more success, as we expand this offering. Renee, additional information you want to add to that?
No, I don't think so. I think, knowing that in the limited basis of the naltrexone that we've been using and able to see the reduction in the return to the jail post 90 days, post 180 days after release, by adding the buprenorphine and the methadone, I think we're just going to increase those numbers.
Thank you so much for that feedback. So being respectful of time, that's all we have time for the Q&A portion today. As I mentioned previously, we'll compile those questions and answers and distribute to attendees as soon as possible. Thank you.
Thank you, Ronnie. All right, everyone, thanks so much for sticking with us. To wrap things up today, I have the great pleasure of introducing Cheryl Kubiak, Dean of the Wayne State University School of Social Work and Founding Director of the Center for Behavioral Health and Justice.
Thank you, Nicole and Ronnie, for putting this together so adequately with other members of the CBHJ team. I want to be very mindful of the work that was put into this, and also thank the courage of our trailblazers, these counties who have gone into the work that is very difficult within this collaboration between healthcare providers or behavioral health providers and the jails. So thank you very much to the presenters, our funding sources from the Michigan Opioid Partnership and Health Endowment Fund and the state. And finally, to all of you who have engaged for the last 2 hours in this webinar. I appreciate that, and I want to just do a couple of quick housekeeping items. One is the satisfaction survey. This is the first webinar that the opioid treatment ecosystem has put together, but it won't be the last. So your comments would be very important to us. The evaluation will pop up on your screen as soon as we end here today, and I would appreciate your filling that out. The next is the continuing education credits. There were 2 social work credits that were offered for this webinar today. I understand that some of you have had some difficulty with that registration, and Ronnie Kaysen of our team will answer any questions. If you email her, it's RAHNI.CASON@wayne.edu. She can answer any questions and try to troubleshoot that for you. There will be a survey that you will need to fill out that will be emailed to you directly after this presentation. If the survey is not completed, that you will not be eligible for those continuing education credits. So again, my sincere thanks from all of us at the Wayne State University School of Social Work Center for Behavioral Health and Justice for your commitment to this issue and helping us help others fight this other epidemic that hasn't been out in the limelight right now. But we know it exists, and we know that you're all on board and committed to changing this current process. So take care and stay safe, everyone.